So kind of while we're making the transition here to doing even more of a deep dive into clinical and financial integration, I noticed some questions of Lauren a half hour or so ago. You're asking a lot of questions about Stanford, and he said Stanford didn't tell him, wouldn't tell him, et cetera. And what's going on in the Bay Area, a lot of stuff going on and so forth. I actually have some insight into that. And the way you do these things, of course, is with your students. So I teach healthcare strategy among my courses, and it's going on now, winding up. And I have them form into teams, 5 or 6 students each, to do strategic plans. So one of the groups this semester did a strategic plan on Stanford strategy, particularly Stanford Children's, Packard, and buying up all these primary care practices and so forth and so on. One of the things I think I can say, because I think this is public, Lauren, but maybe if not, I should start going like this, but tell me if you know this. Stanford Children's, Packard, part of their strategy now is to have a physician presence, this is on the children's side, Packard, within 10 miles of every child in the Bay Area. You know about that? I think they're public about that, sort of. But the students then went 30 pages about how they're doing that, whether it's going to work, competitor analysis, what UCSF Benioff is doing, and so forth. But the fun part is I had another group that's doing a strategic plan on UCSF Benioff, okay? So I see both sides and what they think the other side is going to do, and of course vice versa. And it's really interesting, but there's a lot of dynamics going on. And one of the keys, as far as I can tell, what you all know, so I'm just underscoring what you know, it's about execution. It's about being able to execute the strategy. And there's going to be some differences there, I think. And UCSF Benioff, Salesforce guy gave him a bunch of money, and now they have, as you know, Oakland Children's is a part of it as well, and how they're going to make that work remains to be seen. But in any event, that's just a little bit of a transition. So I get the pleasure really of moderating our next panel. What I'm going to do, though, is take maybe 10 or 15 minutes to lay the groundwork platform for others to work from. And one of the things I've learned over the years that when you're a moderator, you should set low expectations at the beginning and let your panelists be the stars. So if any of this bores you, it's only going to get better and better with the other panelists. And I was reminded of this a little bit. Did any of you see the movie, what was it, the hotel in India? Yeah, the old Marigold Hotel. Yeah, and there's a sequel. Marigold 2 is out. And there's a scene in there in which Maggie Smith's character goes over from London to America to actually close the deal on the hotel back in India. And she returns, and her friends give her, kind of welcome her back at high tea, and they ask her, well, how was America? And she says, well, I went over there with low expectations, and I came back disappointed. So trying to set the expectations here. But we will at least try to provide a foundation. So as you all know, this is what we're trying to do, the triple aim, et cetera. Improve quality, constrain costs, improve population health. Some people think that's an iron triangle. You can have 2 out of those 3, but not all 3. But it depends on what you think the reality is in terms of current data about whether or not we're at any kind of efficiency frontier, and I think most of us agree we're not. So maybe it's a way to get a win-win-win if we could do some of the stuff we've been talking about this morning and early afternoon. Here is what it's going to take, okay? Here's a triangle. I like triangle. Incentives on the one hand, and this is about ACO contracts, and we had, Greg, you're absolutely right. It's about the contract. That's on this side, the incentives, okay? On the right-hand side, or over here, down here, is the capabilities. I don't know if that's working or not. And that has to do with the organizations, the different organizations, and whether or not they're going to be able to respond to the incentives. And this is where we're going to get the winners and the losers. Some will, some won't. We need to try to get smart about predicting which ones will and which ones won't, and where payers and others and the Medicare are going to place their bets. Medicare, a few years ago, placed their bets on 32 pioneer organizations, right? And most of them lost money. Some made money, and overall there were savings because it was around a few, 5 or 6 of them account for all those savings that you're beginning to see. Some have left the program. They're still committed to accountable care, but the Pioneer model at this point is not for them. And then a lot of this depends on the metrics, and Jerry's going to talk about that and others, I think, as well. The transparency that we need to find out what's really going on, and also for internal quality improvement purposes as well. So when we look at these in terms of antitrust issues and so forth, we really need to delve into some of the metrics that the partners involved are trying to measure and pay attention to. And we'll say a little bit about that. And of course, the value proposition is indicated there as well. So some fundamental changes in both payment and delivery are what we're talking about. So I do want to define terms. I think they've come up a little bit throughout the day, but to make it explicit. Financial integration. I think, Katie, this thing, the battery is worn out, but in any event, it refers to, and this in Lauren's presentation, right? Lauren was not talking about clinical integration, as he indicated. He's talking about structural organizational relationships, okay, management of assets under various governance and organizational models. They can be horizontal, right? Hospitals acquire hospitals, physician groups acquire physician groups. Vertical, a lot of that we think is occurring now. Hospitals buying physician practices. They can be virtual arrangements. They can be loose alliances. They can be joint ventures. That's what we mean by financial integration. Don't confuse that, okay, with other forms of integration, or when you see in the literature integrated delivery systems and so on, it's usually talking about this. And what we think we know is this is not where the payoff is. This is not where the payoff is. And they've learned that in the UK as well. It's not necessarily about organizational models. This is where the payoff is going to be. It's what happens to patients and populations of people. And this here is just a working definition that a lot of us use. The extent to which care provided to patients is coordinated across activities, conditions, providers, settings over time. So it has a longitudinal trajectory to it, but you can chop it up and look just at episodes or whatever, right? So as to maximize the value of care delivered. Now you can unpack each of those and do an hour lecture on them and the metrics behind that. We don't have time to do that now. We will get into that a little bit with the panel. But here's the key question that brings the two together that we're searching for. What organizational forms can create clinically integrated care? Okay, that's the empirical question. A lot of different forms are out there. A lot of different ACOs at organizations have these contracts, at-risk contracts, where they're at risk for both cost and quality of care for a defined population. But it's the contract that makes it an ACO as such. But a variety of organizational types have those kinds of contracts, right? So that's the distinction I want to make, and kind of building off of some of the comments this morning. So we've done some work. We're working with colleagues at Dartmouth with Commonwealth funding, trying to learn more about these ACOs. We have a national survey of ACOs that we've been doing for about 3 years now. This is the result of some early work where we've been able to develop a taxonomy of what some of these organizations might look like. This was in Health Services Research about back in December, I guess. And essentially, using 8 attributes, we've been able to classify them into 3 categories. And I'll just list, I don't have a slide on it because I want to do a deep dive into this. There are some of these ACOs that lump together using 8 characteristics, and these are orthogonal. They really separate each other out, that are indeed integrated delivery systems. We call them that, okay? They have a bunch of other characteristics, but that's perhaps most understandable. They are larger, they provide broader continuum of care, et cetera, et cetera, et cetera. They have somewhat more sophisticated electronic health record functionality. There's another group that we call physician-led. They are physician practices, physician group practices mostly. They are smaller. They don't have some of the sophistication of these other ones here, but there are other things they do quite well on, so they sort of cluster together. There's a third that are hybrid, okay? They are joint hospital physician-led, sometimes a local coalition-led. Community health centers are sometimes a part of these as well. And there's definitely a hybrid category. And they tend to be in between on a lot of these 8 dimensions. If you're interested, it's in the article. But here's an example of how you might drill down and use a taxonomy like this rather than saying, oh my God, there's 750 ACOs in the United States now. Levitt Brothers kind of charts these things, and there are over 750 now. But here are some of the things you might want to look at. So for example, how do they hold the doctors accountable? Okay, what are some of the metrics or processes they use? And none, individual quality measures down to the individual doctor level, down to the cost measures for each doctor, okay? One-on-one review and feedback, we do that. We do have individual financial incentives for them, or we have non-financial recognition. I have a Harkness fellow now, Maddie Phipps-Taylor, who's from the UK. She's doing her project on this, and she's looking at the non-financial as well as the financial. And she's been doing 4 intensive case studies trying to look at how they split things and so forth, and some national data as well. And I think I can say, based on what she shared with me without identifying the sites, that they seem to give as much, if not more, attention to the non-financial as the financial. And there are things like recognition, sharing data and information, opportunities to improve your care by, okay, for this next 3 months, you get priority with the diabetic nurse educator, for example, because we've agreed that that's something to work on with your patients. So it's things of that sort to assess the physician. Well, you can see the differences here by the taxonomy, by the type. So the physician-led are the vertical stripes, I believe. Yes, they are. And you can see that they score high on individual quality measures, percent of that type that are using those, nearly 90%. They're high on the cost measures. They're high on one-on-one review and feedback. Why? Anyone? Just thinking about these IDSs and what I've just said. I can cold call, maybe I'll cold call Nickman, you know. He's given up being a professor, I guess. He's really doing important work now. Well, largely we think it's due to their electronic record capability. They have the metrics, okay, and they can use it to do some of those kinds of things. That's not it alone, of course. Then we have the hybrid and the IDSs. The IDSs are the solid ones. I'm sorry, I misspoke. It's the physician-led, okay, that actually do more of that, okay? Forget what I just said. What I just said is true, but the IDS-led that have the more sophisticated record, they're not really getting that information back so much. We think, because of site visits we've done, they're large, they're complex, they're dispersed. Week after next, we're visiting healthcare partners in LA, and 8 sites, and they're all over Los Angeles, and then Advocate in Chicago, and it's all over Chicago, northern Chicago mostly. And they have a hard time getting their arms around those kinds of systems. The smaller physician-led, right, they can just turn around, they have one site, maybe a few sites, they know each other very personally, and so they're the ones that are really able to work with the doctors on a personal level. And the hybrid, as you can see, are somewhat in between. So we are able to break down the data a number of ways like this with various questions we have in the database. This is a model that Elliot Fisher and I largely developed a couple years ago. It's a framework in which a lot of the research we're beginning to see and in future work might be understood, so to speak. And when you think about antitrust issues and looking at given markets, this might be a useful framework to think about it, really understanding that local environment, the history, the politics, the past legal decisions, investments that have been made, market structure, IT capacity. So that's the environmental context. The local readiness to take on risk. This is a big issue, the ability to take on risk and how you assess that. We had a side project here a year or two ago where we developed a readiness assessment instrument for safety net organizations in California. That's been used to some extent by safety net organizations in terms of are they ready to take on these kinds of risk-based contracts. Actual implementation to chart the intermediate outcomes as indicated here. Do we see improvement in care, process measures, et cetera? Do we see improvement in health IT capacity? And the subject of our panel, what about the degree of integration achieved? That's clinically integrated care, not financial integration. And then in turn, the ultimate question is any of that related to improved access and patient experience, improved health functioning, and reduced costs, right? The triple aim. And in particular, we're trying to build in patient-reported outcomes of care. The study I noted earlier with healthcare partners and Advocate, we are using patient-reported outcomes in addition to clinical metrics to look at whether or not those two risk-bearing ACOs and individual practice sites, the role of patient engagement. Are there variations by patient engagement in the outcomes of care and patient activation measures and so on? So this may be of some interest. Just a few more. Okay, we believe at this point in time, based on work that we and others have done, some of it data analysis, some of it site visits, working, triangulating between the two, 6 big things. And this comes out as some work we did with the Berkeley Forum and also other kinds of experiences as well. I'll just hit the highlights of these. The panel will elaborate on some of this. Size matters. Size and scale really matter. As you know, the Medicare, they only had to have 5,000, I think it was under the shared savings at least, way too small. In our national survey data we have, I think it's up into the 100,000 range is more like the mode, and some, of course, are much larger than that. So to be able to spread, it's not just the economies of scale that you normally think about. Think about the motivation to do this to begin with. Why would you make these hard investments, et cetera, and take all the grief of trying to change people's behavior for 5,000 lives? You know, you got to have a much bigger carrot out there in terms of the numbers involved to do some of that. Care management is absolutely key. There's just no question about it. That's where a lot of the value added is, we believe, and it has to do with fundamentally rethinking the way in which clinical care is given. The clinical workflow, it's difficult. It's not just hiring a diabetic nurse educator, but it's mapping out that entire process and thinking about, why is that patient even coming to see me to begin with? Okay? It's really doing root cause analysis. And it's about the predictive analytics, which gets down to this here. Knowing in advance who your population really is and who you shouldn't be seeing at all if you're really doing things in the community to prevent that visit. Remember now, assumption, you're being paid to keep people well, okay? You're being paid to keep people well. And so if you have to expend resources seeing them in your office, never mind the hospital, you know, that's out of your pocketbook and it's not contributing any value. This is important, obviously. Partnerships are really key. This is one of the things we're learning, and I'm sure Jill will talk about some of her case studies that they've been doing. The big thing here is the post-acute continuum of care. The primary care is critical, but the other big cost, particularly around the readmissions, is what you do in linkages to home health and nursing homes, long-term care, rehab, et cetera. And a lot of these ACOs don't have those relationships. Particularly the physician-led ones don't. IDS more so, but the physician ones don't. So they're trying to learn how to engage and develop effective partnerships, strategic alliances, and so on. And that's slowly beginning to happen. This is a real big one we're real interested in. Hector Rodriguez and I are, as I say, doing some work around that. And there's a paper that'll come out in Medical Care Research and Review on some work we did early on, funded by the Moore Foundation, where we have data on 101 ACOs and the extent to which they're doing this stuff. And the answer is not very much. But we did make 2 site visits. One actually was to UCLA Medical Center and one to Group Health Co-op up in Seattle. And we learned quite a bit from that. And then we did 11 phone interviews in depth, subsample of the ACOs who completed the survey. So we learned some things from that. So if you're interested, I can talk to you more about that. I want to speed up here. And I mentioned that. That's really critical as well. So The punchline here is not one-offs. It's all of these things together. They operate synergistically. They're interdependent, that we're likely to get the highest probability of success in beginning to achieve this triple aim. So I'm sure this will be modified over time. You can add to it. You may disagree with some of these, but this is what we have found up to this point. And that sets the stage really for our great panel. I'm just going to introduce them briefly now, and we'll probably come up in this order, if that makes sense. So Jerry Kominski here from UCLA, professor there in the Department of Health Services, School of Public Health, and also the director of the Health Policy Center at UCLA. And for years, they've been doing the California Health Survey, the CHIS. That's been an invaluable resource in the state. And among other things, probably Jerry's going to talk about some of the quality performance metrics and also this issue of balancing clinical and financial integration. Jill, funded by Robert Wood Johnson Foundation and colleagues at IHA, and Jamie Robinson on our faculty have done 4 case studies here in California. She's going to highlight some of the lessons from that. Bruce Bodaken, who is a member of the faculty at UC Berkeley. That's his big title now. You know, no longer president of Blue Shield. That's, you know, he's on the faculty at Berkeley. You've been promoted. So he's going to talk about ACO sustainability. He's also been doing some work with the Institute of Medicine around that as well. Ken Kizer, who is distinguished professor at UC Davis and also heads up the Population Health Institute at UC Davis, will probably underscore some of the issues around clinical integration. He's also been involved and studied the St. Luke's case, which is really interesting. I know it's familiar to many of you. John Wiegand is here, and we need legal expertise with all the rest of the characters we have here. So John's going to talk about, in particular, the antitrust implications of some of what we've been talking about today. And then we're going to bring Lauren back again and perhaps myself back again to make some comments. So with that, Jerry, you're up, and we'll tee up the slides.
Thank you. I think it's a little ironic that I'm here today to talk about quality measurement. I've spent most of my career looking at issues related to payment reform, financial incentives. But when Steve invited me to participate in the panel and in this conference, it occurred to me that the other disclaimer is that in contrast to a lot of today's speakers, I don't spend most of my time working on ACO-related issues. Most of my research over the last 5 years is focused on the impact of the ACA, and obviously ACOs are being heavily promoted as a result of the ACA, but I've been spending my time building a microsimulation model to help California understand who's eligible for benefits under the ACA and who's likely to sign up for those benefits. And now that we've had 2 rounds of open enrollment, who are the people who are eligible for benefits but not signing up for them? So on a day-to-day basis, I'm thinking about sort of the nuts and bolts of how do we get people enrolled in health insurance that's newly available, and why are people still not enrolled in those programs? So this was a welcome opportunity to sort of look at other aspects of the ACA and other significant changes that are going on. But the irony, to me at least, of my talk today is that given my interest and my background, that quality performance and quality measures are probably the last thing that, you know, even 2 years ago, I would have predicted that I'd be interested in talking about. And yet it occurs to me in the context that Steve just laid out that clinical integration is really a key to the success of whatever we want to call them, integrated delivery systems, ACOs. The financial arrangements matter, but they're not preeminent. So I think it's a good opportunity to look at where we've been so far with the Medicare program, and specifically with the Medicare Shared Savings Program. So what I'd like to do is spend a few minutes going through results for year 2. And Anne Marie made a comment earlier that we probably should have a conference on standardization of quality. Believe me, those conferences are happening, will continue to happen over the next decade, and they've been happening for a long time. This is just a reminder of the 33 measures that CMS is using fit into 4 major domains: patient and caregiver experience, care coordination and patient safety, preventive health, and the at-risk population. You've got 33 measures in these. Some of them are composite measures, and the scoring system that CMS has used in the 2014 reporting year is basically 2 points for most of these categories, with the exception that one of the preventive health measures related to electronic health records counts for 4 points. But basically, you get a maximum of 14 or 16 points within each of these domains, and then you get a percent score based on how many points you actually scored out of the possible 14 or 16. And then those are averaged, and you get an overall composite percentage score for quality. So what is for the 220 Medicare Shared Savings Program ACOs in year 2, what's the distribution of those possible composite quality scores look like? Well, we've got quite a range here of scores in terms of overall quality, ranging from as low as 40 to 45% of the total possible points, up to a handful scoring better than 85%. You've got distinct clustering in the 70 to 85% range. But the fact is that these quality scores, I think it's fair to say, are a little bit all over the place. They're certainly not highly skewed towards the right-hand side. And I'm not sure that we would have expected that. On the other hand, it is, again, as somebody who doesn't look at these numbers on a day-to-day basis, somewhat surprising to see, a lot of scores down here on this end of the distribution, a lot of ACOs scoring at the low end of the quality scale. Overall, although I'm not showing it in the slide, average quality did increase, and CMS reported that between year 1 and year 2. So this distribution, although it shows a wide variation, represents relatively significant improvement in average overall quality between year 1 and year 2. The data also has been broken down by a different ACO type. And Steve, I don't know if you've had a chance to look at this. This is from the Health Affairs blog article that was published in December. And I don't know how the ACO types here, I didn't have a chance to see how they map into the taxonomy that you've developed. I assume that it's similar, if not exactly the same, but I'm not, yeah. I just don't know exactly how, I didn't have a chance to go in any further, but you can see there's some interesting differences here. First of all, the groups are relatively large, and although I don't have the p-value here, there is a significant, the physician group led ACO types are significant. This is a significantly lower overall quality score. So I think there is some good evidence to date that they are not performing quite as highly as the hospital systems or the hospital and physician group systems. There's a lot of different ways of looking at the individual quality indicators, and just want to summarize some of the most important findings for year 2. Overall, ACOs did improve on 30 of the 33 quality measures, and as I mentioned, CMS highlighted that and the fact that overall average performance on the quality indicators improved in year 2, and that's good, that's encouraging. I've already mentioned that the ACOs with physician and hospital groups had the highest scores. When you look at the individual members, they were the individual measures, they were the highest on 13 of the 33 quality measures, scoring highest on shared decision-making and qualifying for EHR incentive payments. And that's where they had the largest advantage relative to the 2 other types. In contrast, the physician group ACOs had the lowest scores on 24 of the 33 quality measures, and they were substantially lower on composite scores for diabetes and coronary artery disease. And I guess, again, as a non-clinician, I find that a little discouraging because I would think that Steve's slide showed that it was the physician-led groups that seemed to be sharing data and at a higher rate, had a higher proportion of shared data. And it seems to me that these composite conditions are ones where the sharing of data would make the biggest difference. So it's a little discouraging, I think, to see those low quality scores. And then there were two scores related to ambulatory care sensitive conditions that had by far the lowest overall scores of all the quality measures, scoring in the low 20s in terms of percentile rankings. There are also some interesting regional differences here, and these also, I didn't include the p-values again, but these are statistically significant at I think at the 5% level as well. And maybe for some people in the room, these results would be somewhat discouraging given the growth of ACOs in California, but the Pacific region scored the lowest in year 2 for the 19 ACOs reporting, with New England and the West North Central scoring the highest. And this is, in my opinion, kind of a considerable spread. It's almost a 10 percentage point difference. So there are significant differences across the country.
And you only looked at after 1 year?
That's right. That's right.
It's interesting to see if it moved it around, right?
Yeah, exactly. Exactly. So those are the data. Let me just sort of wrap up my comments by talking a little bit about the balancing of clinical and financial integration, and I wanted to make it a few general comments. I too believe that effective partnerships are clearly an important ingredient in achieving clinical and financial integration. And I guess it's my sort of judgment or opinion that clinical integration really needs to take precedence because it requires shared culture. And I've heard several speakers today talk about that kind of shared culture. How do we measure it? Where does it come from? I think it's an enormous challenge even under the best of circumstances. It doesn't, we can do the financial arrangements, but building a culture of quality and of cooperation is something that the financial arrangements in and of themselves will not produce. So I think it's important to specifically focus on clinically integrating the services of ACOs. Now, one theory that I think is useful in this context is relational coordination theory. And I think that Steve's work and some of the slides that he presented provides a very appropriate framework for evaluating the intensity of clinical integration. My familiarity with relational coordination is because it posits that successful coordination requires shared knowledge, shared goals, and mutual respect, that it's an appropriate framework for assessing the effectiveness of some of the ACO partnerships. And this is a way of sort of drilling down on how integrated are the organizations. Because I think the intensity, that's really, several speakers have talked today about classifying the degree of integration, and I interpret that as well to be, if we can carry that further, the intensity of integration of services, which I think is extremely important. I also think from a public health perspective that realistically, and Steve also alluded to this in his opening comments, that the full triple aim, though desirable and critical, may be beyond the scope of ACOs, at least at this point in time in the near term. And I think I'm basing that statement on the idea that if you really believe in the social determinants of health, that ACOs, making them responsible for population health in a social determinant of health model means that they're going to be responsible for about 20% of the outcome. And I know the state of California, for example, in its current Medicaid 1115 waiver application, is looking for ways of integrating social determinants of health into the next waiver to find effective ways of integrating community-based services, community organizations that are not just healthcare providers in order to improve the health of California's Medi-Cal population. And I think that in the longer term, this is going to be the challenge for ACOs. How do we go beyond the arrangements for coordinating healthcare providers and providing coordinated care to providing the broader context, meaning incorporating the broader spectrum of services that really improve health. I'm a little disappointed that Stuart Altman could not be here today for the conference. I know that he was originally scheduled to be part of this. And for personal reasons as well as professional reasons. Personally, Stuart was the person who first hired me out of graduate school to work in Washington, D.C., so I always enjoy seeing him. But I think that he would agree that Medicare, and I've been thinking a lot about the 50th anniversary of the Medicare program this year. Medicare has in many ways led innovation in healthcare delivery and trying to create incentives for a more efficient delivery system. As an observer of the American healthcare system, I'm often somewhat disappointed, particularly when I go internationally and speak to audiences and who ask me to explain, and I'm sure many of you have had the same experience, trying to explain our crazy quilt patchwork system, which is not really a system. But Medicare has led in a lot of ways. It's created the incentives and has put goals out there. So, you know, whether or not you think the 33 measures that CMS is currently using to measure quality for ACOs are the best measures, and again, we could have a conference to discuss sort of the characteristics of those quality measures. The fact is that we've got them. We can measure performance for these ACOs, but I'm really interested in knowing how does this compare to Medicare Advantage plans, but I'm also interested in understanding how these quality measures compare to commercial ACOs. And the fact is that we won't have that information unless Congress decides that it's going to require this reporting for all providers. And so what we'll do is we'll continue to muddle through. We will have conferences. We'll try to measure the impact of Medicare ACOs and wonder how they compare with commercial ACOs. And even in Lauren's presentation, we can look at Medicare fee-for-service data, but we don't know what's going on in the rest of Medicare. So I think that those are some of the greater challenges that we continue to face above and beyond the integration and the taxonomy, but actually measuring performance and measuring performance relative to all of the other options and all of the other actors that are out there in the marketplace. We have a fragmented market, and as long as we have a fragmented market, we end up having many different ways of measuring quality and performance, none of which allow us to compare across sectors. And I think that that's an ongoing challenge and an ongoing problem. It's sort of like if for environmental protection or for automobiles, we had a different set of standards for every manufacturer, and said, well, Ford we'll apply these standards to the Ford manufacturing company, but GM is going to will have a whole different set of measurement standards for them. It doesn't make sense, but that is sort of the system or framework in which we continue to function. So I will close my remarks there, and thank you very much for your attention today.
So it's really a pleasure to be here, and the timing is great for us in terms of we're coming to the end of a 2-year project that we have been undertaking looking at the emergence of ACOs in California. I thought I would just start with a brief word about the Integrated Healthcare Association. I think those of you who are in California and certainly at Berkeley are well known to us, our friends and colleagues, and others may not know who we are. We are a membership organization in the state of California, and we encompass a whole range of stakeholders. And our primary stakeholders and participants and members are health plans, physician organizations, and hospital systems. And we have, Steve's on our board as well. We have also a range of researchers and pharmaceutical companies, consumer advocates, purchasers, so that we represent the entire array of stakeholders in California's healthcare system. Our flagship program is called Value-Based Pay for Performance, and the P4P is sort of a hangover from earlier days. The program's really shifting into essentially a shared savings program based on resource use, with adjustments for total cost of care trend and quality. So it's a really different world for us and for our stakeholders in the commercial HMO space. That program covers about 9 million Californians, about 200 physician organizations, about 10 health plans statewide. So that's sort of the backdrop for who we are. And so one of the things that we like to do when we have the opportunity, which we did in this case, is to do market research and analysis that both gives us insights and allows us to share our knowledge and expertise and relationships to move the field. This project on the evolution of ACOs in California is a partnership, as Steve mentioned, between our team at the Integrated Healthcare Association and Jamie Robinson and Kim McPherson at UC Berkeley. And we recruited these 5 physician organizations. And we use the term PO at IHA, and it generally encompasses both medical groups and IPAs. Ultimed is the largest FQHC in the country, based in Los Angeles. Brown and Tolan is an IPA model based in San Francisco. Healthcare Partners is a large medical group-based model that has an IPA as well, based in Los Angeles. They have been bought out by DaVita, so some of you may know that. It's now DaVita Healthcare Partners. St. Joseph Heritage came in under a hospital system, so St. Joseph Hospital System. Heritage is the medical group component of that. And Monarch, which is a large IPA in Orange County that has an IPA component as well, and they were bought by Optum. So some of the dynamics of what we were hearing today playing out more on the horizontal rather than the vertical world with these folks, and but really interesting dynamics nonetheless. So all of them agreed to participate in this study. We were fortunate to have it extended through June rather than March, and we're wrapping it up. We were looking at structure, strategy, payment arrangements, and performance. And this just gives you kind of the high-level snapshot of what we did so that you have a sense of what were the knowledge base that we are coming from with respect to some of the key findings that I'm going to share with you. So as I said, we started this about 2 years ago, and because we run that pay for performance program in the state, have extensive information in-house that allows us to do comparisons. We have both clinical quality data, patient experience data. We also now have total cost of care data and appropriate resource use at the physician organization level. So we were able to do some comparisons of that. I'll talk a little bit more about that in a minute. And then essentially we did 2 rounds of interviews, site visits, 2 physician organizations, those 5 across the state, one in the summer of 2013, another one in the summer of 2014. We also did 2 rounds of interviews with health plan executives for plans that are leading big ACO business. And those were by phone in the fall of 13 and the fall of 14. And then now we are in the product output phase. We published an article last fall in JAMA on total expenditure using the total cost of care data, and we are poised to put out 4 issue briefs summarizing our findings across the rest of the study. This just gives you a big picture snapshot of those 5 physician organizations, and they go along the columns and their product lines in the rows. We were particularly interested for this purpose in the ACO products, so the Medicare fee-for-service ACOs. We also looked at ACOs in the commercial PPO space and in the commercial HMO space. And I'm not going to go through all of the check marks, but the high points were that the first three, Monarch, Brown & Tolan, and Healthcare Partners, all had Medicare fee-for-service ACOs, either Pioneer or MSSP. We also saw a fair number of contracts in the commercial PPO space, and then a couple in commercial HMO. And Blue Shield is particularly big in that space. I wanted to set a little bit of context for the emergence of ACOs in California. We have a very long history of managed care in this state, which has led to a lot of expertise within physician organizations that are capitated and delegated to provide care for commercial HMO. Also very strong competition from Kizer, and if you go around to the POs and plans, you will hear a lot of orientation towards competing with Kizer. Often more so than with each other. There's strong interest in ACO arrangements on both physician organizations and health plans in a lot of areas in the state, and this is in part because if you look at the numbers for commercial HMO enrollment, which is where a lot of the expertise has been built in the POs to do commercial HMO business. Outside of Kizer, those numbers are declining. And so if you're a physician organization, you're looking around at how you can redeploy all of the skills, infrastructure, and capabilities that you've built to care for your capitated population, and how can you redeploy those and make the pie bigger. ACOs are an obvious potential. Someone mentioned that a relative paucity of action in Medicaid in California in ACO. I think that is largely because the entire Medicaid program in California essentially is capitated. The state basically is delegated that risk and pays premium capitation to the health plans to care for essentially all of the Medicaid population. And then finally, it's important to think about the launch of California's exchange, Covered California. And I think this is a really interesting development because it provides a possible landscape for the emergence and development of ACOs for 2 reasons. One is that choice is at the individual level and not the employer level. So you have the option. It makes it easier to get in the game rather than having to go through employment market. And the second is that the geographic market can be smaller. It's 19 regions, so you can make a big play in one of those 19 regions and potentially pick up a fair bit of market share, which is often in the commercial HMO space, you really want to have a statewide network. So just a few takeaways looking at, in particular, the Pioneer ACO experience. And one of the things that became clear was that there were a couple different strategies that the ACOs took. One we called land grab, which was sign up as many docs as you could, and those docs would all bring their patients and you would have this scale. And the other was more selective. And the more selective clearly won. The reason was sort of twofold. One had to do with the essentially the risk profile of the population that was enrolled, and that some of the, that if you ended up with lots of oncologists, lots of, very sick people, your cost profile just looked very different than if you had a much stronger primary care network. And the second was that when you chose your network of docs based on the strength of the ties to your physician organization, you were much more successful. Those were the docs that used your EHR, that refer within your own network. You just have much better, more efficient practice pattern profile when you chose a more selective network, and that led to greater success. We learned it was really difficult for these folks to get the inpatient and ED data that they really needed for care management, and I won't belabor that because I think that is probably not news to anyone in this room, but I'm happy to talk more about it if it is a surprise. Steve mentioned the post-acute care issues, really tough to manage the SNF population and that utilization. And high-level summary, mixed financial results. Monarch and Brown and Tolan continued on with Pioneer. Healthcare Partners shifted into MSSP and left the Pioneer program. On the commercial side, we saw a lot of variation. We've heard here, I think, that you've seen one ACO contract, you've seen one ACO contract. In our gathering of the information, we saw two main models emerging, HMO, and what we saw in the HMO ACO was a shift back towards a more global risk, so that the HMOs were capitating the physician organizations for professional services, but under this HMO ACO model, there's also significant potential upside, shared savings for the inpatient side, pharmacy, lab, and so forth. So shifting back towards a more global risk picture. On the PPO side, what we saw was the standard fee-for-service negotiated fee schedule, but supplemented with a care management fee, which could be for the entire population with a relatively low fee, or a larger care management fee just for the chronic patients. For both the PPO and HMO models of ACO that we observed, there was no savings. If the ACO didn't show savings, no bonus was realized regardless of quality. So you could hit the quality numbers off the charts. If there's no savings, there's nothing to divide. End of story. And what those benchmarks look like varied a lot. Whether they were compared to own performance last year or versus the market, there was a lot of variation in that. And obviously the benchmarks are make and break. And that's what we see on the Medicare side as well. It depends a lot on what your benchmark is set going in, how you're able to do against it. We also found that referral management was really critical, again, getting back to that selective network and how well you're able to keep your folks inside. Because once they go outside of your network, you can't control them and you can end up with some very significant costs. You can also make your patients happy by keeping in network because their out-of-pocket costs stay lower, and it's easier for them to get their needed care. Mixed financial results on the commercial side as well. With respect to patient engagement, no surprise, I think, here either, but it is worth reiterating. It's really hard to engage these patients when you have no real connection to them. They're just attributed with data on the back end. They don't know you, they don't know ACO, they never heard of this, they don't want to know from you. You can have all the disease management programs you want. I didn't choose you, I don't know who you are, leave me alone. It's actually really, really hard. And Monarch has this great story about having a non-trivial group of their attributed Pioneer patients living in New Jersey when they're in Orange County. It's just completely, try to manage their care. So it's just really tough. The physician-led communication with ACO patients trumps the plan-initiated outreach. And here the key was the most successful patient engagement attempts did not come at all from the plan level. It didn't come from the physician organization level either. it came from the doc. So if you talk to, for example, Brown and Tolan, they would not want the plan contacting the patient. They would not want to contact the patient themselves either, because the patient doesn't necessarily know Brown and Tolan. They want the doctor's office to do the outreach to the patient, and then Brown and Tolan can support them. So you're really thoughtful about what is the perspective of this patient going to be, and how can we create the supports at the physician organization level and the plan level to support the doc in getting their arms around the patient who really doesn't want to be managed. We were surprised that there was not more hospital engagement with ACOs in the state, and some of the POs really had trouble getting hospitals engaged. So they were physician-led ACOs. The hospitals are like, we don't want anything to do with you. We're doing just fine. Billing as we are. Thank you very much. We're not going to share data with you. We don't really want you to know when your patients are admitted, because then you'll come manage them, and that doesn't really. So this is all kind of subtext that actually isn't a conversation that happens. But their real struggle is even knowing when your patient's been hospitalized. In your HMO, you have a contract. They have to tell you. You can manage them. And that's just not happening on the ACO side. So surprise, your patient's been in the hospital for a while, or your patient was in and discharged, and good luck managing that post-discharge bill and the SNF now that you've figured out that they're there. A lot of action in the hospital side is really more in creating vertical integration strategies with physician organizations integrating up, or hospital systems integrating up and down, and new models. Someone mentioned earlier the Vivity model in Southern California, which is an interesting early development. Dignity is a notable exception here, and the PERS model was mentioned earlier, so I won't go back into that, but they really have been out in front, I think, based on their sense that this is going to come, and so they better get in there and figure it out. Paper, you should read it. It's really interesting, very consistent with what's been mentioned multiple times today. So I won't go into it except to note that there's a typo here. So the basic concept is that we looked at physician organizations that are owned by themselves, by the docs, at physician organizations that are owned by local hospitals, and physician organizations that are owned by multi-hospital systems. And compared to the doc-owned physician organizations, the local hospital ones had a 10% higher total cost of care, and the multi-system hospital ones had a 20% higher total cost of care. So my typo's in the second bullet. Sorry about that. 4-issue brief coming out. I have 2 of them here. They're in pre-publication layout, so I can't give them to you, but there are 4 altogether. They'll be released in the next month. You should read them. They'll be amazing. Tell Robert Wood Johnson how good they are. And this is our team. Tom Williams, many of you know, was the previous CEO of IHA and is now VP and General Manager for Accountable Care at Stanford. And Laurence, colleague, or at least partner in crime. Jamie Robinson here, Kim McPherson here at UC Berkeley, and Kelly Miller, who's on my team. So happy to take any questions when we have a discussion.
Well, it's a pleasure to be here. It's always good to be involved at Berkeley. I've really enjoyed the relationship we've had over the last couple of years and doing some teaching. And while I knew many of the faculty, getting to know them better has been interesting. And so working with Steve and Richard and Brent and Kim and others has been very gratifying from my standpoint. I'm currently retired, so that's my official placard. The things I'm doing outside of retirement include I'm a visiting scholar at Brookings, which includes being involved in leading projects out of what's called their ACO Learning Network. And that's run by Mark McClellan and others at the Engelberg Healthcare Center as part of Brookings. I also have been on the IOM Value and Science-Driven Care Board until recently, and I'm just finishing up a project on quality metrics, actually, with them. And we're waiting for the study that Bloomberg did and others, and that's out now in terms of the areas of quality that not just ACOs, but other integrated systems ought to look towards. And we'll be finishing up that work, and also sustainability in that context. I'm also leading a project, just started kicking off a project on value-based products and looking at whether or not those are another means of accelerating value-based payment, and particularly ACOs. So I'm enjoying that. And it's been interesting, and I guess my perspective today is perhaps a little different, perhaps the same as others. Sustainability of accountable care organizations is something that, in my opinion, we need to face now rather than later, even though we know we're in a development phase. So there's been an awful lot of work. Steve and Brent and many others have done great work on both, and Jill, have done great work on emergence of ACO models, how they might be classified. A lot of work has been done on sort of the essential elements, the checklists that an ACO needs to really be thinking about if they're going to enter into the ACO space. Lots of peer studies on that. Most of this in Medicare, a little bit in the commercial side. I'm only working in the commercial side. I'm not focused on Medicare. There's a lot of other people focused on Medicare. My own opinion is that actually CMS probably will invest some resources in commercial ACOs as well as, but that remains to be seen out of the Innovation Center. But at the very least, there are lots of carriers, Blue Shield, my former employer, and most of the large carriers are all investing some way in value-based payment, most of them in ACO arrangements around the country. And so the commercial ACOs, it seems to me, probably haven't had as much review as they need, and I would suggest that there hasn't been enough review on both results and the sustainability of those results. So we all know about Hill Physicians and Dignity and Blue Shield generating $100 million of savings over 3 years for CalPERS. That's public and is a home run. I mean, they did very well. But not a lot of people are asking the question, what's next for that particular ACO, a little less other sophisticated and more mature models. So that's where I'll focus my attention today. So again, it might be thought that it's too early to focus on ACO sustainability. After all, we've only been at this for a few years. Isn't it really too early to even talk about whether or not the results we've seen so far are sustainable out into the future? And I guess my point would be there are mature, sophisticated organizations that have had several years of results that are either published or can be published, and we know what that means. And we also know in talking to them, because I've been in conversations through my work at Brookings and IOM with both carriers, sophisticated provider organizations, and ancillary organizations about their progress and their prospects for the future in the investments of these more mature models. And so there is a real track record there that I think we should study it and try to understand whether we're seeing elements of that, of the more sophisticated, the larger in most cases, organizations that have the financial wherewithal to be sophisticated and make the investments in IT and infrastructure. Are they seeing the results? And are they seeing the results they've perhaps gotten in the first 2 or 3 years going out into the future? And I think that's an open question. So the challenges to sustainability that I've seen in our work is first, the mature models, if you talk to those that have run these, is they initially got big savings just doing the things that all of us knew we needed to do. It didn't require really sophisticated true clinical integration, didn't require interoperable data systems, it required physicians, hospitals, and carriers in most cases working together to ensure that the patient care was high quality and, as importantly, low cost. And most of the organizations, actually, these organizations, because they started probably a step ahead, having the resources, got that very quickly. Most of them are somewhere up the tree, getting close to the treetops, and many of them are asking themselves what's next, because it's less clear now how they generate the level of savings. And in fact, one of the problems I can tell you, for Blue Shield, Hill, and Dignity is their success has gotten to be kind of a challenge because, in my last bill, purchasers aren't saying, oh, great, you saved me $100 million. Now all I expect is $10 million this year. They're saying if you could do that for 3 years, why couldn't you do it for 10? And so their own success in some respects has made that conversation much more difficult. It's actually whet the appetite of purchasers for these organizations, not for organizations that are less sophisticated, and that creates a kind of problem. Also for these, I think we all know the dilemma of physician organizations in particular, but provider organizations as well, of all types, living in this dual world of volume versus value. We all know that. It gets even more difficult for these organizations because they've gone past the tipping point towards value. They're in some cases 60, even 70% invested in value-based payment. But that 30% still is the difference between them surviving and thriving. And yet all of their attention, all of their resources, all their investment for the most part over the last several years has been on value. And that's starting to be a real challenge because they can't give it up. And of course, for hospitals, they're not at this point, but for physician organizations, they can't give it up, but at the same time, they recognize that further investment in that side of their business doesn't really have a return based on their model and strategy. And so getting that last 10 or 20% out of their business is going to be a real challenge because there's always going to be fee-for-service, at least for the next decade, maybe longer, around. And so they've got to deal with that. And I think the third bullet, others will all mention that this issue of real-time data that can be acted on by the clinician at the point of patient care and can be reported on and shared with others is very difficult, certainly in the less sophisticated organizations. The problem is the more sophisticated organizations have invested millions of dollars in infrastructure, and they're still not there. And they don't know how many more millions it's going to take to get there. And that's starting to be a new conversation with them, which was, okay, we all kick in a couple $1 million, we make the kind of investment we need to make, and now, hold it, we still have to make another $2 million investment? Yeah, we're big organizations, but we can't just keep writing checks. Where's the return? And in fact, the purchaser pressure makes it even more difficult because they want those returns to continue at the level they've been at, which requires more reinvestment. So facing those challenges, in my view, just very quickly, require a few things. First, understanding this distinction of startup costs and ongoing costs. I can tell you when these first started, the commercial side of ACO started, Blue Shield was a very early entrant, maybe the earliest entrant of any size into commercial ACO space. And there was only questions around startup costs. We weren't thinking about long-term big investments into the future. And in fact, Blue Shield was making a lot of the investment on behalf of the physicians, but we were willing to do that to get this started because we believed it was a real opportunity to get someplace in this healthcare system we've never been. But now the ongoing costs have to be understood and they have to be part of the business model. And I would also suggest that the IT policy that's been put out, which is helpful, the ONC meaningful use rules, all of that is helpful. It's not nearly enough, and it's not really focused on ACOs. So I met with at a conference last week with someone from ONC, and we talked about having specific ACO standards that are, if you will, meaningful use ACO standards that go much further, and we talk about incentives that could be much larger because they're going to have to be if they're going to get over the hump of this issue of ongoing investment. And also the mature business models, it seems to me, have to understand better than they do now the difference between short-term and long-term savings. The idea here is we invest a bunch of money, we get on the roller coaster of making real savings, we distribute part of it to our customer, part of it to the respective partners in the arrangement. Well, now, most of the internal sharing has to go back into reinvesting into the system. And so there isn't much to share if we're really honest about it, even the ones that have done very well. That's a problem. And again, this notion of having a 1 or 3 year business plan is not enough for ACO. We should be talking about 5-year and 10-year business plans if we really think we're going to get over the hump to what I would call full sustainability of ACOs, which can take many years, but we should be thinking about it now. For mature ACOs, all these would apply to a less sophisticated ACOs, but they apply even more, I would argue, for mature ACOs. This notion of having strong leadership and governance, especially physician leadership, is in some respects the sine qua non of success for these organizations. But it's in their ability to weather real failure that is going to be the test, because they're not going to continue to succeed at the pace they've succeeded so far. There isn't going to be $35 million of savings every year for CalPERS from Hill and Dignity. I don't have any inside information. I can just tell you that isn't going to happen. That kind for 40,000 members, commercial members, that kind of savings is huge. And they are not going to be able to deliver that year in and year out. And that is going to be perceived in some sense by the purchaser as a failure. That management team is going to have to stand up, be able to explain why they should continue to invest in this concept and why over the longer term the savings will be much greater than they would have with another model. And that'll be tough. But they have to have that kind of commitment and understanding of the future. We talked about clinical integration earlier, and that's certainly part of what this investment is all about. But even again, in these sophisticated organizations, they had clinical integration going in some respects. But now it's really based on having that shared data. And if they don't have that, and in many cases they still don't, it's not the kind of clinical integration that drives having the data available and the human behavior change that has to occur at the physician level. And until that happens, these ongoing level of savings and ongoing improvements in quality and patient engagement are unlikely to happen. Integrated technology for the long term, by that I mean not just EHR, which is I think, fundamental step for a successful ACO, but having more of a dynamic look at that, and we'll talk about that in a moment. And then understanding who really, of the partnership that is developed, do we really know who's going to make the investment in the ongoing years to continue to support the success of this organization? Sure, it will come out of savings. But what if it needs to be more than that in any given year? Are we clear about our personal or individual responsibilities as organizations and our commitment to this enterprise? And often that's not clarified up front, even with organizations that have been working together for years. How these are seen in the market, from my point of view, is, if we could see it, is the senior executives in these organizations really signing up for a 5-year plan would be my hope for these organizations, is that they can look out into the future, understand there's going to be some speed bumps, understand that they're going to have to make probably more investments in the next few years than they anticipated, planning for that, looking to outside resources to help them with that, grant-making organizations, foundations, et cetera, but continue to make investments around a primary care model that can deliver over time increasingly better performance on cost, quality, and patient engagement. And that's got to be the commitment. Again, communication is critical to any good ACO, but this notion of transparency is transparency at the level, again, in this notion of disappointment and failure. Sharing with every component, every physician, every partner, and every relationship, just where you are on the continuum of success. And understanding that is going to be important. And I think that's tough for organizations to do. We want to talk about the successes. It's much harder to talk about even lessons learned in some cases. If we see it, this is how it would look. Flexible IT systems that are able to track the improved health of a defined population. This notion of predictive analytics and risk stratification Steve mentioned, I think, is critical. We still don't have the systems that do that, and again can be part of a shared data system. EHRs, as I mentioned, are just a start, but they're not dynamic. It's not a dynamic. If I know it's great. I mean, it's a hell of a step forward to know what tests were run, what steps were taken in this patient's history. We didn't know that often when we went into the examination room. The physician didn't know that. Now we know that in most cases. But it's really, what's the next right thing? Not, okay, I know what was done. Maybe I don't have to run certain tests again. But what is the right next thing to do? And that kind of system that is dynamic and is helpful as a decision support tool for physicians, again, is still not in the offing. And EHR vendors have not done a great job of making their systems interoperable. They're just starting to open the gates of that kind of closure and walls. They're starting to take those down. ONC's put a lot of pressure on them, and they've gotten some commitments from the vendors to do that. And I would argue in the future, this whole notion of social media, privacy, having an encrypted network that allows for secure messaging to patients, to other clinicians, video conferencing, other forms of communicating with patients, all of that's going to have to be stood up over the next 2 to 3 years if we're going to address a commercial population. Finally, is it ACO success at risk, given everything I said? I don't know the answer to that question. I would say this. All real experiments of any sort that have any value are imperfect in their origin. If we think about even the notion of HMOs, a little less preferred networks, and we wouldn't think of a commercial product now that didn't have a network as part of its makeup. It's just assumed. Well, I was here when it wasn't assumed, and we had to go out there and do battle with physicians to try to get contracts. The reality is now, the idea that you would actually offer a product that didn't have a network, it just wouldn't make sense. And so things happen over a long period of time, and then they become the givens, and that, I think, is likely for ACOs. It needs, again, to have the right policy context so that people understand these short-term and long-term trade-offs, both at the policy level, the government level, and I think the institutions themselves, like hospitals in particular, understanding this will be critical. I mean, one of the things about the CalPERS case is I worry a little bit about declaring success too early. It could cloud our judgment as to what success ultimately looks like for an ACO. If we expect all of them to perform at that level, I think we might be disappointed, so I'd be careful about that. I would say there's no other mechanism or initiative that has had this kind of policy, government, and private sector focus. And that's a good thing, because I think that interest will allow us to reinvigorate, re-innovate around this concept. And so I'd say the support, the timing, the fact we're all taking our time today to do this bodes well for ACOs. And somebody else can figure out whether they're legal. I don't worry about that. I'll assume that's the case. So thank you very much.
Thankful for the opportunity to participate in this conference, and I do need to start with the typical government disclaimer that the comments that I'm making here today represent my own views and may not fully comport with the official views of the Commission or any individual commissioner. I thought that addressing the subject of clinical integration and how this fits in with our analysis, it would be nice to maybe take a step back and look to see how we arrived where we are today from a historical perspective. So, in the beginning, hospitals and physicians created integrated delivery systems. They looked at the systems and they called them physician-hospital organizations. Remember those days? The FTC looked at those and said, wow, we know what those are. Those are joint ventures. Those are arrangements among competitors. We have tools that we know how to use to analyze arrangements that look like this. Those tools date back quite a ways. You might think back to cases involving sports leagues, like the Board of Regents of the University of Oklahoma versus the NCAA, where the court looks not quite rule of reason, not quite per se, some kind of truncated rule of reason. That's the case where the Supreme Court said we could accomplish the rule of reason in a twinkling of an eye. That line of cases got crystallized and came down to a well-known commission opinion in a case known as the Three Tenors. And that's the kind of framework that we would use to analyze physician-hospital organizations, joint ventures among competitors. And we look and ask at first, well, do the agreements among competitors within this joint venture constitute behavior that is inherently suspect? Well, when we're looking at organizations of competing physicians, the issue is almost always joint pricing. And we know from everyday life that joint pricing among competitors is something that is inherently suspect. There's probably nothing that's more suspect than joint pricing among competitors. So the answer to the first question was always, yeah, it's inherently suspect. So then we got to the next question. And the next question was the restraint, or is the restraint justified? Is it justifiable for these competing physicians to engage in joint pricing? And the legal approach said, well, there's really three factors that need to be met. That the justification needs to be legally recognized, legally cognizable. It has to be economically plausible, and it has to be reasonably necessary. And we thought, well, how are we going to apply this abstract set of factors to physicians and joint ventures that might include hospitals as well? Well, the business, the healthcare providers kept asking for more guidance, and we at the FTC eventually issued a set of enforcement guidelines in 1996, most recently, and we said, look, in order to apply these kind of abstract principles to the healthcare field, we're going to say that there needs to be either financial integration, there needs to be clinical integration, or and those factors need to make the setting of price on a joint basis reasonably necessary. In legal speak, that's somewhere between convenient and absolutely essential. So we operated for a while on that kind of standard, and we had a lot of questions about, well, what does this really mean? Well, financial integration was a little bit easier for us to define than clinical integration. The reason for that is, at the FTC, we employ half a building full of economists. So we're a little more adept at working with financial things than we are with clinical things. We don't employ any doctors at all. So as to financial integration, we said, well, there's a number of ways that could be achieved. There could be withholds or bonuses based on performance. Or there could be capitated contracts. And whenever you set out certain standards of requirements for a prerequisite for doing something people want to do, they want to cheat on the standards, right? So we started having a string of investigations about phony financial integration. There's a consent in a case called New Millennium, a bunch of orthopedists in the Cincinnati area, where we basically said the withhold and bonus system was fake. They set it up with the idea they already knew they were going to meet it. There's no doubt that they were going to get the payment. Everybody knew it. It was just a front so they could say, well, the FTC comes around, don't worry, we have a system of bonuses and withholds. We've looked at a couple of cases of phony capitated contracts too. That would be those cases where there's so many outliers, there's so many patients that fall into the stop-loss category that almost all the payment ends up being fee-for-service. Every patient's stop-loss. You go into the doctor twice, you're on the fee-for-service. So we know that whenever we establish some kind of guidelines, the cases are going to be about cheating on the guidelines. So we also then moved to look at the clinical integration standards. And because we have a little less experience with the practice of medicine than when we do with the accounting for money in businesses, economic questions, a little more cautious in treading here. And doctors were always asking us, well, why don't you just give us some rules? You've said you want clinical integration. Tell us what that is. Give us a checklist. Just say, here's the list. Here's 15 items. 12 out of 15, good enough, you win. Just give us that list. But we resisted that for a long time, and I think for good reason. There's a real danger for legal standards to be proclaimed and then set in stone. You may remember that Supreme Court case from 1927. Remember the case about the automobile and railroad crashes? The Supreme Court said, we've had enough of these cases, so we're going to establish the rule once for all. Here's the rule. When a car comes to a railroad crossing, the car needs to stop, the driver needs to get out and look to see if a train is coming. That case was overruled in 1933. It only lasted 6 years. You might ask, who was the bozo who wrote that? Oliver Wendell Holmes. All right, there's a danger in establishing some kind of standard because it freezes thinking at a particular point. And it is a inhibition to innovation. And if there's one thing we know about clinical practice and how doctors are seeking to address clinical issues is there's change all the time. And if the government comes in and sets a particular standard, then that kind of freezes things in a certain place. These programs are approved by the FTC, so we need to have these programs. And maybe they were good at the time, but they're no longer the right programs. Or what's good for one practice in a particular place may not be good in another place. We resisted establishing a firm checklist. We don't have the expertise for it. Maybe the closest thing that we could have for a glimpse as to what the agency sees as clinical integration would be a report issued by an expert that we hired to testify in one of these cases. And there's one of those. It's written by Dr. Larry Castellino, then of the University of Chicago, now of Cornell. The case was North Texas Specialty Physicians. It's part of the public record. You can look it up. You can see the programs that he laid out at that time as being indicative of what real clinical integration is. Programs like clinical guidelines with electronic reminders, nurse case management programs, disease management programs, registries for patients with chronic diseases, physician performance peer reviews for both efficiency and quality, patient education, common system of electronic medical records, and any kind of program that compels the collaborative work of physicians in providing physician services to patients. That's a glimpse of at least one view that the FTC paid for. We do pay our experts. That's available to the public. And if you're forming an ACO today, and you're looking only for that ACO to be available for commercial patients, you don't have to meet any of the CMS guidelines. That's the kind of standard you're under. But with the advent of ACOs, there's another approach you can take. The FTC presumes compliance with CMS rules will require clinical integration. So if you want a nice checklist that was devised by a government agency that has a lot more experience with clinical issues than the lawyers and economists at the FTC have, you can go the checklist route. And we're not going to challenge whether by going through that checklist and being blessed by that process is authentic clinical integration. We're going to accept that as being true, and they have the expertise. They can modify that checklist because it's within the scope of their knowledge. So as far as the other aspects of analysis of ACOs, we issued in 2011 a set of guidelines that give folks shortcuts, allow them to be in a safe harbor. The The level of analysis is not particularly complex or sophisticated, and therefore we only look for it to establish safe harbors, not to decide every case or especially close cases. But the key elements of that are that geographic market is defined according to the lowest number of zip codes that is required to draw 75% of the patients of the participants in the ACO. Now, if you think about it, that's a nice shortcut. It works reasonably well. But you think about it, it's going to create some anomalies because it's going to perhaps bring in a distant zip code that's really huge in population, and therefore providing maybe a small percentage of its patients, and it might leave out a zip code that's closer, has a very sparse population, but contributes 90% of the folks who live there to the providers within the ACO. So we can see that this is a shortcut that in most cases is going to provide a rough analysis that will tell those involved in forming the ACO whether they're going to be in antitrust trouble or not. So the geographic analysis is the 75% zip code standard. The service analysis is we're looking at each service medical specialty as a distinct product market. We realize that that's not always perfectly designed, and we might not in every case withstand close analysis, but it's a good rough guide to start. And as to market share analysis, say if you're within 30% with those market definitions, be in a safe harbor. We have established some special rules for rural areas, but on the whole, the analysis here is kind of nice because it allows organizations that are considering the formation of an ACO to have, at least on the clinical integration side, a very detailed set of instructions that they can choose to elect to go if they want to go the CMS route. If they want to go purely the commercial route, then they can go with the more flexible but less exacting traditional FTC standard. So I look forward to your questions, comments, criticisms in the later period. Thank you.
Good afternoon. My comments may be a little bit different. They are not about an ACO per se, although they build on some of what John was just talking about. And I was asked to talk specifically about the ongoing, although hopefully it will be ended sometime before too long, the litigation between the FTC and others and the St. Luke's health system in Idaho, and what some of the lessons from that litigation may be that would be relevant to ACOs. So with that, let me just give you a little background, and I should probably say as a preface that unlike most, or essentially all of the other high-profile FTC provider consolidation cases which have involved hospital mergers, this is about the acquisition by a hospital or health system of a large physician multi-specialty group. So it's a wrinkle, or kind of a new wrinkle on an ongoing theme. But in the way of background, St. Luke's health system is one of two major private providers in southwestern Idaho. That's this part of the state where most of the Idaho population lives. Boise is here, and that's where St. Luke's is, or at least their flagship hospital is, and then this is primarily the area that's covered. But both St. Luke's and St. Alphonsus, the other primary private provider, cover this area as well as some of Eastern Oregon. There are other providers in the area. The VA, as in most metropolitan areas, is a substantial provider of health care, and then there are some smaller ones. The Salzer Medical Group which was the acquisition in this case, is the largest multi-specialty physician group in Idaho. Had about 40 physicians, about 3/4 of them were either adult or pediatric primary care physicians. St. Luke's acquired Sulzer in December of 2012. And this was just the latest in a series of acquisitions. I forget the exact number, but it is around 20 or so previous acquisitions of physician groups in this general region, although most of those others were single specialty groups, cardiology, orthopedics, et cetera. The St. Luke's asserted, when this became an issue, and originally St. Alphonsus and a small private for-profit hospital, Treasure Valley Hospital, challenged this or began to challenge it, and later the state of Idaho Attorney General and the FTC got involved. But as St. Luke's asserted that they had achieved demonstrable quality and cost efficiencies through their prior acquisitions, and that the acquisition of the Sulzer Group, just the latest in an ongoing series, was necessary to achieve their objectives of reducing or improving quality, reducing costs, all the stuff that we're talking about, and that full financial integration, i.e. ownership, was clearly the superior method for doing this, and was essential to achieve clinical data interoperability through common use of or through a common electronic health record, to promote data analytics, to align physician incentives with the health system incentives of improved quality, reduced costs, et cetera. They also, interestingly, claimed that a core number of primary care physicians was essential to provide integrated care. This, as I've already noted, was challenged by the Federal Trade Commission and the Attorney General and others who claimed that this would violate the antitrust restrictions because, in essence, it gave St. Luke's control of about 80% of the primary care market in the Nampa area. I don't have the map up there, but Nampa is an area just north of Boise. That's one of the growing suburban areas of the region. So the key issues in the case, at least from our perspective, there were other issues that were perhaps of more interest to the Federal Trade Commission about geographic market and market concentration and those sorts of things. But the key issues from the perspective of ACOs, perhaps, is employment of physicians the most effective way to achieve clinical integration and the associated benefits? Is it the most effective way to align physician and health system goals, to achieve data interoperability, to promote data analytics for population health management? Also, is this idea that there is a core number of primary care physicians essential or necessary to provide integrated care? And the big question, of course, is, was this acquisition anti-competitive and violate the Clayton antitrust law? So the decision, as I suspect most everyone knows at this point, is that it was deemed to be anti-competitive. And at the district judge level, the judge opined or ruled that the healthcare costs would likely to rise or would rise as a result of the acquisition, because the combined entity would be able to negotiate higher prices or higher payment rates from insurers, which would then be passed on to the consumer, and that there would be higher costs for ancillary services like x-rays, et cetera, because those would go through hospitals and other reasons. And importantly, the conclusion was that there were other ways to achieve the stated and desired goals than the acquisition per se. This case has received a lot of attention in the press. St. Luke's did not accept the district court and did file an appeal. with the Ninth Circuit Federal Court. That was initially the appeals court sided with the district court, or at least the initial foray, which involved just actually a segment, a portion of the entire bench. St. Luke's appealed that and wanted the full appeals court to hear the case just about 2 weeks ago, or within the last 2 weeks. That was declined, and so the issue now that's confronting St. Luke's is, do they try to take this to the Supreme Court? And that will play out as we go forward. So with that as the context, I think there are at least 5 lessons or so that are relevant to ACOs. The first is that ownership, full financial integration, whatever label one wants to put on it, is not the only, by any means, nor the most effective way to achieve clinical integration and the associated cost and quality improvement advantages that go with that. I think perhaps to underscore some of what has already been said today, integrated patient care and integrated delivery system are not synonymous. That has become kind of the mantra in healthcare, but full financial integration is not synonymous with or even necessary to achieve clinical integration. Integrated delivery system, as Steve commented earlier, there comes in lots of flavors. There is no standard definition of what constitutes an IDS, and certainly the lack of complete or nexus between financial and administrative integration and clinical integration is well demonstrated by the VA in the early 1990s. VA was unquestionably financially and administratively integrated, but was anything but clinically integrated. Even the Department of Defense and they have 2 health systems, TRICARE and the military treatment facilities. There is no more financially and administratively integrated system than the military treatment facilities, but they are not models of clinical integration even today. They're certainly better, they're improving, but again, those 2 things don't equate with each other. And I think, as perhaps at risk of being repetitious, achieving clinical integration is really dependent on a number of key organizational functionalities and not the organizational structure, and that no single organizational form has to date been shown to be superior to others in achieving integrated care. The way that I've looked at this, which comports pretty well with what Dr. Shortell and others, there's actually a not robust, but a reasonable literature, and certainly for those of us who have run large integrated delivery systems, lots of experiential data on what or how you achieve clinical integration, and they basically fall into these 7 functionalities. How you view and conceptualize how healthcare should be delivered, and having that vision that's both patient-centric and population health-focused, having very clear policies and procedures for coordinating care across a continuum of settings and providers and time, et cetera. Strong clinical leadership. If one had to pick one component out of this, by far the most important is that strong clinical leadership, although I think it's important also to underscore, as has been said at least a couple of times today, that it's not any single of these, it's the combination of these functionalities, and the synergies that result from that combination is what drives effective clinical integration and the commensurate or associated improvements in quality and cost improvement. Information management tools, candidly, get too much attention in my mind. They are essential to achieve the sort of data mobility that's needed, and it's not just electronic health records, but it's health information exchange, it's clinical decision support, it's data analytics. But there's also this other supporting infrastructure, the human resources, the contracting ability, those administrative support functions, because you can have all this great data and have all these things that you should do, but if you don't have the associated administrative and other infrastructure to implement that, then none of those things are going to get realized. So the need for the supporting infrastructure is critical. Team-based care, methods of accountability, performance measures, and then a way of sharing financial risks. And again, much of this has already been said at least 2 or 3 times today. Some other lessons, the St. Luke's asserted early on that it had achieved certain efficiency and quality goals. I think unfortunately, those didn't stand up to scrutiny. So the lesson here is that these assertions of improved efficiency and quality have to be more than aspirational, however nicely packaged, but they have to be more than speculative. To do that, you need baseline data. Where did you start from? Where did you get to? You need the evidence of improvement really has to withstand that scrutiny. The improved function has to be clearly linked to the consolidation that occurred, and these improvements somehow should be part of an overarching strategy or coherent strategy as to why or what was being sought by the consolidation. Employment is not, the third lesson is that employment is not required for physicians to gain access to electronic medical records or data analytics or some of these other tools that are necessary for population health management and quality improvement. This assertion that a core number of primary care physicians is essential to provide integrated care. I'm not quite sure where that came from, other than it seemed to come out of the blue because there is no evidentiary base anywhere to support that assertion. And then the last lesson, perhaps, is that employment of physicians is not necessary to align incentives and to transition to value-based payment, nor is it required to achieve clinical integration. There is a lot of discussion about financial incentives, and while financial incentives have their place in aligning incentives, I think, as was noted in this article and others, that health systems too often neglect to engage their physicians. And really, if you want to get alignment, you have to engage your physicians, and that involves a number of other things that have nothing to do with finances. And with that, I think I will sit down, having exhausted the time, and perhaps we'll have some further conversation and discussion.
The one thing I want to say is to go back to something that Jerry said earlier, Jerry Kominski, when he had that slide about relational coordination. I mean, I wonder what's that about? It's kind of floated in from somewhere. It seems theory and abstract. It's really important. Not only, he talked about 3 of the 7 attributes. This is a measuring instrument. It's very easy. Okay, it's commercialized, so I'll talk about that in a minute. So yes, mutual trust, mutual goals, and respect, but then the other 4 elements are communication. And they have to do with the accuracy of communication, the frequency of communication, the timeliness of communication, and is it problem focused? What the instrument does, it gives it at the frontline level to the people who are caring for the patient. So this might be a medical assistant, a nurse practitioner, a physician, primary care physician, and they complete it in terms of their roles, and they evaluate it on 5-point Likert scales, and you can aggregate it up. And I mention this because we are using this instrument. We are taking Jerry's suggestion to heart in this study we're doing of these 2 large ACOs. And what we're doing is we're taking 8 practices at Healthcare Partners was mentioned today in LA, 4 of which have scored high on a baseline independent assessment of the extent to which they're engaging their patients, and 4 low. We're maximizing the variance. top 4, bottom 4. We're doing the same at Advocate in Chicago. And we just got out of the field. We went in with the relational coordination instrument. We got a remarkable 94% completion rate at Advocate and a very respectable 72% at Healthcare Partners. They deserve a lot of credit for that. And we're now analyzing that data. But the most important thing is that we're going to then relate it or correlate it with patient activation on the part of patients. We're using Judy Hibbert's PAM measure, 13 items on whether or not patients feel they have confidence to engage with their doctor. And then we're going to look also in terms of the clinical outcomes of care, blood pressure, and patient-reported outcomes, functional status, also the depression scale, and so forth, and we're going to do it over time. And we're going to be able to administer this twice. So the bottom line is, our hypothesis is that the more these ACOs, down to the individual practice site, are actually communicating around patient-centered care with each other, they know each other's roles, the better the patient outcomes. We're also going to track costs to some extent, but because it's PCORI funded, we can't say much about that because they're not funded to do cost effectiveness analysis. So it's really a very important point. It's also a tool that can be easily used as well. So Lauren, do you want to make a brief comment to start with, and then we'll just open it up?
The cost-benefit calculation, whether I should hear from the rest of the panel. I would actually, so what here, okay, one quick one. The summary of all my comments is the financial incentives really matter, that it's going to be, we're going to get clinical integration faster when we get the incentives aligned for the physicians and all the players to really want to do clinical integration well, and that's when we're going to get to sustainability in these organizations, and that's what we have to be thinking about. And part of that is when patients and the folks who would create a market advantage can recognize the value of these organizations, and when doing better at clinical integration, doing better at delivering high quality care drives market share for these entities. And that's maybe the biggest shortcoming in the Medicare program at the moment, and maybe it's something that's emerging. But I'll leave it there. I think the incentives are ultimately going to drive all of this at the end of the day, and when we get them right, and when it's in everybody's advantage, then we're going to get this stuff figured out, and that's the fastest way. So that could have been 5. That's my short comment,
and that'll
I'll let
be
everybody
necessary,
else comment.
but not sufficient for all. That's where we're going to see the winners and losers. The incentives will be there, but some of these folks will be able to deal with them, and some will not. Yes, right. Say your name quickly. Yeah.
Paul Hastings, as far as I know. Nobody called to tell me it changed today. Taking up on Dr. Baker's, Professor Baker's point, so this idea of creating alignment through financial incentives, we know from the vast literature on retail distribution and resale price maintenance that is very difficult, if not impossible, via contractual remedies, the principal agent analysis that Ben Klein, Roald Coase, and legions of others have sort of demonstrated that that's almost impossible via contracts alone. And I've always sort of wondered, since the FTC appears to have such a fetish for contract as opposed to structural integration in this space, like how they reconcile the learnings from the resale price maintenance space with the preference for contractual remedies or integration that we seem to know like won't work from an economic perspective.
And the question is specifically then?
Like, well, how about this? Does that seem like a coherent question, Professor Baker? And then maybe John would answer.
Yeah, I was going to say, Ken and John, I share the general question. I actually think the FTC got it right in this case, and I think there's lots of reasons for that. But it does leave open this question of how well can we get the incentives aligned if we don't have employment. I tend to think we can, but I'd leave it to some experts to think about how we move forward from that basis.
John, any comments you want to make on that?
Well, I think it's important to note that the theory that the FTC pursued in St. Luke's and the theory upon which the district court and the Court of Appeals made their rulings were purely horizontal theory.
But that's not like an actual answer, right? Because the challenge is creating coherent integration, whether or not you can identify specific segments where people compete or not. And we know from the vast literature on vertical integration that that's extremely difficult to do without an employment relationship. because the gross margins are different. Like, so how you create, specifically, particularly if you don't allow nonlinear pricing, like I think if you don't allow a nonlinear pricing schedule and you don't allow employment, you cannot align financial incentives. I think like is a strong hypothesis from the economic literature. Any disagreement about that? Hearing none.
The economists in the room.
Right.
So,
No, I think that.
yeah. So I would just, the only thing I would add is, I don't know that literature nearly as much as you do, but to think about a portfolio of that motivate professional behavior. So
Working in a law firm,
financial
very
incentives are
difficult.
a big one, employment, but there's a whole portfolio. There's even, I don't know, a meeting the other day, some experimental work going on, very interesting, intrinsic versus extrinsic motivation. Maybe
Sure.
you know
Dana
this.
Ariely has done some great work
Yeah.
on this, and he'll have a forthcoming paper. But
But it's difficult.
scaling and creating consistent results, like, pretty hard.
Yeah. Okay, other questions? 2 or 3 more? We can, yep, right here.
Yeah, just to briefly, Josh Sovin from Gibson Dunn, just to briefly answer Tom's question. I think once part of the concern is that once you allow the consolidation, you can't undo it. If you do it through contracts and you're not happy with the results, then everyone can go back and take another look. I have a question, and I apologize for missing some of the presentations this afternoon. You know, at the end of the day, this is about cash and who gets paid and who doesn't. So for the people, I understand, you know, all the emphasis on all these criteria and these metrics and these organizations. But one of the things I've always sort of wondered about, both in private practice and the government, is it seems to me there's a couple of ways to save money. You can either have fewer employees or you can pay them less. And you can pay them less in the form of either just reducing their salaries or kind of moving the work, if you will, from higher salaried people to lower salaried people. And so for the people who've been studying sort of, you know, where the savings actually come from in terms of the labor force, I'd be interested in their perspective on that.
So I'll start. I don't recall who made this statement earlier today, but I think the answer was in an earlier comment, which is that the only way to achieve these savings, if you can't achieve a significant reduction in utilization, is to have greater involvement of lower priced professionals. They're pushing the envelope of the sort of the scope of practice. And that is what FQHCs are doing. I think it's what Medi-Cal managed care plans are doing here in California. So there's capacity, but it's not among the highest cost professionals. It is finding a way to spread that responsibility for patient care and coordination over a broader range of staff.
The only thing I would add to that, it's lower cost personnel, professionals that practicing at their level, also lower cost settings of care. And then the third rail, though, is actually re-examining the whole way in which the production function to produce health or whatever is operating and take out unwarranted complexity. We have such unwarranted complexity in what we do that there's huge opportunities there for savings as well. So that would be the third rail, I think. Maybe Anne Marie there and then Jim. And we need to get one question from the left side of the room. Remember, we're at Berkeley. We always go to the left. Okay.
Right, I'm Anne Marie Marsharelli from the University of Missouri at Kansas City. Jill, I thought your observation that, I think you were the person who said this, I wrote it down as you, okay? You were saying SNF utilization is going to be the really tough one to, and then you just left it, you know, but of course, I mean, and I thought it was hilarious, I have to say this, in the proposed rule, the new rule for ACOs at the back, they gave us a diagram, those of us who hadn't occurred to us, that the new lower cost venue for healthcare was going to be in SNFs, right? You know, so they gave us a diagram. It's wonderful. You should all open it up. There's visuals showing how they could connect to a SNF. The problem is, how do you do that? And so I guess I wanted to urge you to say, do you have more thoughts about that? Like, that seems to me to be the winning, you know, place, the winning opportunity.
So I am not an expert in this, but I can point you to a couple of areas where there are really interesting work going on, although I might have to actually dig them up and share them. But there was Sharp in San Diego has done some really groundbreaking work on this, and it has to do with just like all of this. There is no magic here. So you want to, it's clinical integration. How do you do it? There's a toolbox for doing that. So at Sharp, what they're doing is actually having their docs in their network show up at the SNF. You have to actually manage the patient. There isn't any shortcut for that. But if the gain, from the improved quality and the reduced utilization is significant enough, then you justify it. So what does that model look like? Robert Mechanic also has just done some really great work on this out of New Jersey, and he put together a fantastic panel that I heard on this topic that I would recommend to you. So it was at last year's Academy Health, for those of you who go to the Academy Health Research meeting, and I'm sure I can dig up the whole panel and send it to you if you're interested in it. I was just fascinated. I thought it was fantastic.
Jim?
I was just going to make the comment. I think you'd agree that that we have seen incomes go down among physicians, and I think nurse salaries are going up, at least in some parts of the country, a lot slower. So I think there's been some of that abatement also.
Yeah. Okay. So one question over here, this side of the room. There is one. Going once, twice. Anyone? Okay. If not, I think people are getting pretty tired, Katie. Richard or anyone else, you want to make any summary comments or remarks? Wind up?
I don't want to keep the panel any longer. It's been a terrific day and a terrific session, but I just want to know if there is uniform agreement, more or less, that clinical integration is in some sense more important than financial integration, or not. Is there general agreement on that? Because I think the guidelines say, the FTC guidelines say one or the other. It's nice to have both, but you don't need both. So I'm wondering if there's some opinions about that. I seem to glean that from the panel, but I'd like to get another run through on that.
Did you want to make a comment, Jim, on that? No. Okay, let's go to Jim first. He's got a thought on that.
I think what the driver is changing incentives. So it's mostly payment reform and all the incentives about that. But I think we as an industry think that in order to really get up the stream on value-based payment, maybe all the way to global payments, we need better integration. So to me, it's the incentives and the need for a new incentive approach. We think requires integration. And that's surely the New York theory, is that the reason we're building these PPSs is so that we can give them more risk, put them at more risk.
Just to end on a little controversy, I don't need the microphone. I think the economist's view would be that financial integration is in fact more important than the clinical.
So Richard?
Drive for clinical integration.
Okay, yeah, but just so we don't confuse people either, the term financial integration, financial incentives, and clinical integration, you may be equating financial integration and financial incentives. I don't know if you are. I don't. I think I agree with Jim. Financial incentives and the economics are absolutely critical, right? And clinical integration is going to, separate winners and losers. When often we talk about financial, we're talking about governance and management, whether or not you need to own it all, you can do it through contracts, et cetera. Employment, maybe employment's the only way to go. That's financial integration. And I think the panel is saying that can vary. We don't know which type of financial integration is going to really help promote clinical integration. But we're also saying today, I think, that, boy, you need the financial incentives. We need to pay for value and not fee for service. Yeah. Over here, John.
Richard said correctly that we state it frequently that you need one or the other, but I can say in my experience, I've never seen successful clinical integration that did not include financial incentives. Otherwise, you would think that the Soviet economy was going to be a real hit. Financial incentives are what make people work right. So.
Well Well said. Okay, on that note, I think we will conclude. I just want to thank all of you on behalf of the Petra Center for being here. It's been really great. It's been filmed. We'll have feedback. There'll be additional steps that can be taken as well. I hope, Kathleen, you and everybody has found it useful also. And I invite you all. We have a very nice reception and dinner up at the Women's Center or the Berkeley City Club. And Katie, do you want to give us directions for that, or should I? Or yeah, Katie will tell us how to get there.
Let's thank everybody.
Yes.
Yeah.